Okay, let's get started. Other people I'm sure will join, but we have a lot to talk about today. Before we introduce our incredible guest, just a few brief introductory remarks. My name is Jessica Levin, and I am the webinar director of Let's Talk Menopause. And Let's Talk Menopause is a national nonprofit focused on changing the conversation about menopause so women get the information they need and the health care they deserve. All our webinars are for informational purposes only, and they should not replace seeking medical advice from your doctor or your healthcare provider. Just a few housekeeping items. We're not using the chat to communicate with each other, so please include your questions in the question and answer section. Donna, our CEO, will be including links and other information in the chat that you can link onto, and you can also copy those links into your own document if you want. And we've also now included a live transcript, which you can look at during the session, and we will also send it to you after. So thank you so much for joining us. There will be a survey at the end, so we ask everyone to complete it. And if you don't complete it at the end, we'll send you a link to it because we want to hear as much feedback as we can from all of you. So I'm thrilled to bring back our incredible guest, Dr. Sheryl Kingsberg. We had her on our February Menopause Talk, and there were so many questions, as there always are about this topic. And we trust Dr. Kingsberg as much as anyone to help us understand what we need to understand about sex in and after menopause. So Dr. Kingsberg is the chief of the division of behavioral medicine in the OBGYN department at University Hospital, at the Cleveland Medical Center, and a professor at Case Western. She is a specialist in treating female sexual disorders, menopause, pregnancy, and postpartum disorders. She's the former president of the North American Menopause Society and the International Society for the Study of Women's Sexual Health, and she now chairs the advocacy committee of both organizations. She is a prolific researcher and writer, and she has authored over 100 peer-reviewed publications and is a co-editor of a textbook on treating female sexual disorders. So we are thrilled that you're here with us. We depend on you to answer all of our questions, and we are glad everyone else gets to reap the benefit of your expertise as well. We're going to try to get to as many of the questions that you all asked today. We've asked Dr. Kingsberg to give a brief overview first, because we find we keep learning when you keep explaining things to us, and then we will devote the rest of the menopause talk to questions and answers. And now I'm going to turn it over to you. Thank you.
Great. Thank you, Jessica. Thanks for inviting me back. I'm glad I didn't screw up too badly the last time that you would invite me back. But now that I know that there's a live transcript, I'm going to avoid as many ums as possible so that they don't show up and my grammar is better. I do have I started with an I have an announcement, which is the North American Menopause Society has changed its name. So it is now the Menopause Society. So it will take me a minute to get used to it. It's been the North American Menopause Society for decades. So the Menopause Society, and they are coming out with a new website that I think will be much more consumer friendly. So please stay tuned and use that because I think you'll find the information will be really helpful. So I want to start, as Jessica said, with an overview, only because I want to put us on the same page when it comes to understanding postmenopausal sexuality and female sexual function. So I always start with my first slide. I love these women, and I think that it just makes the point that sexuality, sexiness, sensuality is not related to your age, and it really is ageless. But the whole reason we're talking today and answering your questions is because it often is not trouble-free. But, look, sexuality and sensuality and beauty is still alive and well in your 50s, your 60s, your 70s. Now, Sigourney Weaver has always been my favorite from 50s, 60s, 70s. I even named my dog Ripley after her character in the Alien movies, Lieutenant Ellen Ripley. I wanted a strong name for a little teeny dog that I had. So please keep in mind that when we're talking about age and sexuality, please don't base it on age. And in fact, the majority of women who are postmenopausal want to and will remain sexually active. One of the biggest barriers to sexual function in older women is the availability of a partner. Okay, so could I have the next slide? Let's talk a little bit about the sexual response. This is across all ages. When we think about sexuality and research on sexuality, there have been several models to describe how sexuality works in males, females, and others. Masters and Johnson in the 1960s really were the first two to empirically study the sexual response, and they brought males, females, couples into their lab, and really they videotaped, they used all kinds of techniques to measure the sexual response in males and females. They had the earliest ways to put a camera in and measure the function inside a vagina. And so based on their research, they said the sexual response is invariable for males and females, and they said it follows this linear progression, starting with excitement, when your body becomes excited based on some psychophysiologic erotic experience. And with enough excitement and with excitement, the vagina for women becomes swollen. There's blood flow to that whole genital area. The clitoris is enlarged. The vagina lubricates. There's an increase in heart rate, temperature. Your nipples become erect. Males and females' nipples will become erect. And that's the excitement phase. With enough appropriate stimulation and no interference, the body reaches a peak level of sexual excitement called plateau. That is the highest peak of sexual enjoyment and pleasure. And then the body moves to orgasm, which is the release of all that sexual tension experienced as pleasurable. For males and females, there is a contraction of the muscles or feelings of spasm that occur about 0.8 seconds apart. And that can go on for a few seconds, and then the body moves to an unstimulated state called resolution, where there's no ability to re-stimulate. Now, women often can have that ability to re-stimulate, and they can be multiply orgasmic. Men tend to have a longer, what we call refractory period. But it is a fairly linear progression. Now, Masters and Johnson did say that there was a gender difference, and I think that may be on the next slide, Donna, maybe. Did I put that? Yes, I did. So if you can see that although they said there's a linear progression that is for males and females, they did note a gender difference. And so you can see on the left that the reflection is this linear progression, but showing 3 different women, or maybe the same woman on 3 occasions, but it could reflect 3,000 women or 3 million women. The point is that if you see the graph on the left for females, you will see a variance of how it occurs, whereas on the right, you'll see for men or for males, it's pretty much the same function. It's the same progression. The only thing between one male and the next, or within the same male on a different occasion, would be duration of that response. But for women, there's a million different responses. And why do I say that? Why is this important? Because for you and for your healthcare professional, it's important to know that even though we think about the responses going excitement, plateau, orgasm, resolution, it could vary from one woman to the next, or within your own sexual response, whether it's based on menstrual cycle, if you're still having one, or it's between partners, if you have different partners, or it could be just over time, or just the experience itself can vary. So woman A, who's in the, I'll call it magenta, goes from excitement to plateau. She has actually 2 orgasms. You can barely see that second orgasm. And that could be her experience. But woman B moves to plateau, but she never orgasms. Now, if this was the same woman on 2 different occasions, we'd say, guess what? That is normal. We do not expect to be 100% orgasmic on every single sexual encounter. But if woman B is the same woman on every occasion where she plateaus but never can reach orgasm, now she's got a problem and probably is distressed by her lack of orgasmic attainment. And then woman C just has a different experience of how she reaches excitement and plateau and orgasm. So again, same woman on 3 occasions, 3 different women. It's important, again, that you know that your way of experience sexual response may differ from your sister or your friend or your cousin because it's variable and your own experience may change. And what I see often, unfortunately, is women will come into my office and they will say, I think I have a sexual problem because I can't reach orgasm with intercourse with my male partner. And he tells me that all of his other lovers were multiply orgasmic with intercourse with him. And so, and I will usually sit her down and explain delusion disorder regarding her partner. And then I will say that the majority of women are not orgasmic with penetration, or certainly not intercourse, and that if she can reach orgasm in other ways, in which she can, clitoral stimulation or using a vibrator, that would be a normal sexual response, and not to rely on somebody telling her what it should be. So her expectation that there's something wrong with her because she doesn't reach orgasm with penetration just needs to be changed, and we need to change those myths. We really need to change those myths. The vast majority of women need external stimulation because the clitoris is key to orgasm. Even if you are able to reach orgasm with some form of penetration, the clitoris is involved. And so relying on penetration alone often isn't going to be enough. Okay, can we go back a slide a minute? And let's talk about the second model of sexual response, which came out from Helen Singer Kaplan in the mid-1970s. Now, in her model, she was a psychiatrist, she said the most important organ in the sexual response is the brain. And that Masters and Johnson kind of omitted talking about desire, because remember, they were just measuring physiology. And so desire really is key to the sexual response. You need to want to want. And so her model was desire, arousal, and orgasm, but still fairly linear. Now jump ahead 2 slides, and you will see the other model I want to talk reflects a nonlinear approach to the sexual response that says you can kind of come into the sexual response. It's not always so linear, and it doesn't always begin with desire. And the reason that we focus on, and I have this titled Sex and Aging, is that this is also particularly an important slide to consider and model to consider when we're thinking about postmenopausal women and women in long-term relationships. Now, that spontaneous desire that Masters and Johnson would have talked about, or Helen Singer Kaplan, may be there. It's right in the middle of that circular model. It's a spontaneous drive. It may be there, but many times, for many women and men as well, you're not necessarily feeling like you want to be sexual. You're not feeling that we would consider spontaneous desire. When you either are receptive to a partner's initiation or you decide you're going to initiate, because we will initiate or be responsive to somebody else's initiation for many reasons other than feeling sort of horny ourselves. That is, we are kind of sexually neutral, but we know that being sexual with our partner might create emotional intimacy, or it's something that will please your partner, or you read in Cosmo, it burns 500 calories. And so there are many reasons besides the drive to be sexual that might have you start to engage in sexual activity. Now, you still are a little sexually neutral at that point. You might be doing the grocery list in your head a little bit, But once you have enough adequate stimulation and you're feeling good about being with your partner and there are no other interfering things like pain, if it hurts when you're being sexual, that will shut down whatever desire might be there. Or if there's a knock on the door, then that certainly will interfere. But assuming that things are going okay and there's some appropriate sexual stimulation and your body starts to get aroused, it's at that point that desire kicks in, right? So arousal actually precedes desire in this case, and not that linear progression. Go back, go back, go back. You skipped ahead. That's the sexual response has to take its time. And so it is then that desire kicks in, and that drives the cycle. So we have, you're starting from a neutral position, but once you get started and it feels good and you feel aroused, that will kick in desire. And we call that responsive desire. Some women will say, that's the kind of desire I've always had. Some women will say, I used to have that real strong drive early in our relationship, but now that we've been together for 15, 20 years, I don't get that spontaneous drive the way I used to. But once we get started, then that's okay, and that sort of takes the pressure off the lack of passion that long-term relationships sometimes lose because of the habituation to it. So I say that to say, look, if you used to have drive and now it's gone, and that is your own sort of intrinsic horniness, that many women will find as distressing. And that's not the same as having sort of responsive desire that comes in a long-term relationship. So we can talk more about that if you have questions, but now you can move to that next slide. Now, okay, so now I wanted to talk about, I think the slide builds, just put them all in there. And when we think about the sexual response, we think about it as comprised of a biopsychosocial perspective. There are biologic factors that will contribute to healthy sexual function and will contribute to sexual problems. We need sort of overall physical health, but there are also hormonal changes that can impact sexual function, neurochemical changes, your neurotransmitters, all that can impact sexual function, disease processes, diabetes, cardiovascular health, all of those things. Psychologically, depression. We know that there's an interplay between depression and sexual function, but clinical depression often has one of its significant symptoms is lack of sexual desire. There's also anxiety issues that will get in the way of healthy sexual function. Sociocultural factors are religious and cultural upbringings that can impact your willingness or your comfort with being sexual. And finally, interpersonal factors, the quality of the relationship. That plays a huge role in particular sexual desire or sexual function. You could have all the drive in the world, but if you don't particularly like your partner or you're in an argument, you're not going to necessarily want to be sexual. Or you may have a partner that's a wonderful lover and that helps your sexual response, or one that is not a good lover and that may cause a problem. So keep all of those factors in mind when you're thinking about, if I have a sexual concern, do I think it's more biologically based, psychologically based, religious and cultural, or is it interpersonal? And maybe it's a combination, which is why there's overlap. It may be one or more of those factors. Okay, next slide. I want to talk about the fact that desire can impact women or lack of desire or lack of sexual function well outside the bedroom. So please know, obviously I'm preaching to the choir. If you're on this webinar, then you know that it's important. But we've done research, and this is one research survey I did several years ago, looking at women who had reported low sexual desire and what kind of impact it had. And look at this, 69%, although the slide is not showing my numbers, but kind of blank there. Sorry about that. 69% would go before that percent sign, had it negatively impact their body image. It wasn't that poor body image caused them to lose their sexual desire. The fact that they had lost sexual desire made them feel less attractive, less feminine. 55% believed that it impacted negatively their self-confidence. 67% said they felt less connected to their partners. 35% said they felt like it impacted their communication in a negative way with their partner. And 35% said they were worried that their partner might cheat. Okay. I think that slide builds. And so what I want to point out is that what we know clinically is that when sex is good, it's good. It adds some value to a relationship, maybe 15 to 20% added value. But when sex is bad or non-existent, it is inordinately powerful, draining that relationship more like 50 to 70%. And that comes from Barry McCarthy's work, several decades ago, and it is still true today. So many women will come in and say, everything else in my relationship is good. We're best friends. We have a good relationship. We enjoy each other's company. We have similar values. But if I don't fix my sexual problem, I don't know that our relationship is going to survive. Whereas most people may have had prior lovers that were great and you had great sex, but there wasn't enough to sustain that relationship, because good sex can only go so far, but really bad sex or problematic sex really plays an inordinately powerful role. Okay, and last, here are my general categories of sexual dysfunction. So when you're thinking, do I have sexual concerns? Think about them in these 4 categories that often overlap. There's problem with desire, which is the idea of wanting to be sexual, right? That's your appetite for sexual desire. There's problems with arousal, whether it's genital, which is really feeling changes in sensation, difficulty with lubrication, feeling less sensitive, but also cognitive arousal, which is when you are sexual, your ability to experience joy in that. Orgasmic dysfunction, the inability to reach orgasm or having a real problem with getting there. And finally, genital pain with sexual activity, in this case with our postmenopausal population, often due to genitourinary syndrome of menopause, which is the change in the tissue without vaginal estrogen or hormones to keep the tissue healthy. So those are our general 4 categories. And with all that, I just want to leave it open to questions so that we have time. Oh, here's my picture of what GSM would look like. Thank you, Donna, for making sure I cover that. You can see on the left, in a premenopausal vagina, and it should go down right into the vulva and the labia and the clitoris, you can see healthy rugae. The tissue is thick and folded and has nice, good blood flow premenopausally. After menopause, if you don't have estrogen or estrogen and testosterone, I'm seeing something on the slide. There we go. You will see a change in the tissue where it becomes thin. You can see the cutout over on the right. Thin and dry, and the tissue becomes very stretched and almost it can be painful to touch, and sometimes will just simply bleed to the touch. And that is what we call genitourinary syndrome of menopause. It can affect the bladder itself because there's also a change in pH from acidic to more alkaline. There's change in the good bacteria versus the bad bacteria, and it affects up to 70% of postmenopausal women. So, and one of the primary symptoms is pain with sexual activity, which is what we're talking about today. So those are my slides, I think. So we can go on to.
Thank you. Okay, we're gonna jump into questions. As I said, we're gonna try to get to all of them. And you can ask questions anonymously, of course. So the first question is actually a great question. Someone is saying, what if they suffer from in all 4 categories? How do you start?
Sure.
What do you address first?
Well, first of all, many women do end up experiencing problems with all 4 of those. The best approach for me when I'm working with a woman is to figure out which is the primary problem that then has a downstream effect. So, for example, if you have no desire, if you are not interested in being sexual, and you try to be sexual, it often will lead to difficulty in getting aroused, right? If you're just not interested, your body's not going to respond. And if it's not aroused, it's often dry. There's not going to be the vaginal swelling, and therefore there's often pain, much less you're probably not going to reach orgasm. So in this case, for that particular woman, right, she's going to have problems with desire that has the downstream effect of impacting her ability to get aroused, no orgasm, and often pain with sexual activity if she tries to have penetration when she's dry and there isn't a sense of relaxation. On the other hand, somebody else might come in and say, I have pain every time I try to have sex, whether it's penetrative pain, which is with either a penis or a finger or a vibrator being inserted, or even at the vestibule or the vulva itself, there can be pain. Then why would you want to have sex if every time it hurts, you're going to be anxious, you're going to be more focused on will it hurt rather than any kind of desire. So you might have had some drive, but that gets wiped out by the experience of pain. And of course, there's probably going to be difficulty with arousal and orgasm. So you can see that, again, I could pick arousal as the place to start, and somebody has difficulty with lubrication or they've lost sensation, and then they get frustrated because they can't trigger an orgasm, and then they lose their desire, and then they have pain. Or let's pick orgasm as the way to start. If you can't reach orgasm, then oftentimes it gets so frustrating that you lose your desire, and then arousal problems, and again, pain. So you can have all four. It is the point of trying to pinpoint which place you want to start in terms of a treatment so that you can meet with a professional that can help you figure out where to start and how to approach treatment.
So there are a number of questions about estrogen, and there's someone who I guess went on systemic estrogen and saw improvements, and then there's questions about vaginal estrogen. So can you first talk about how, when to use systemic estrogen, when that helps some or all of these problems? And then I want to turn to vaginal estrogen because there are a lot of questions about that also.
So again, with menopause, when your ovaries stop producing hormones and you're no longer producing eggs, with that loss of estrogen, many women will experience what we call vasomotor symptoms, hot flashes and night sweats. And most women know that that's what they associate with menopause, right? That can start even before your ovaries have shut down. We call that perimenopause, when your periods are starting to change and they become more irregular, or maybe you go a couple months without a period, or maybe it's change in the bleeding pattern, but you may experience hot flashes and night sweats. And the first line treatment for vasomotor symptoms, if you're uncomfortable with them, would be systemic hormone therapy. If you have a uterus, it would be estrogen, systemic estrogen, either in an oral form or a patch or a spray or a gel with a progestogen, because you need unopposed estrogen will cause a buildup in your uterine lining, and you need the progestogen to help you thin that lining. So it prevents uterine cancer. So estrogen plus a progestogen if you are with a uterus, and estrogen alone if you don't have a uterus. Okay, and that will often be helpful for treating hot flashes and night sweats. There are newer treatments coming out that are non-hormonal, hopefully, for vasomotor symptoms. We're waiting, hopefully, for a product from Astellas to get approved called fezolinetant, which actually is a central nervous system acting non-hormonal treatment.
I'm going to cut in for 1 second because I want to understand, if you go on the systemic estrogen for hot flashes, will it improve these sexual?
I'm getting there. Okay. So for many women, yes, the systemic approach to using estrogen for hot flashes and night sweats will also have its downstream effect and help with urogenital changes, or GSM. But not all women will have enough help from the systemic hormones. So please, if you are on systemic estrogen or hormones and you're still having symptoms of GSM, so dryness or pain with sexual activities, it's not that you may need now a local estrogen. Now, some women may not be on systemic hormones and again will have GSM, genital urinary syndrome of menopause, remember up to 70%, or maybe your hot flashes have stopped, but you will still need a vaginal estrogen. And I would suggest that the vast majority of women should be on some kind of local hormone therapy, whether it's an estrogen in the form of a cream, a pill, a ring, a gel cap, spemifene, which is actually an oral medicine, or vaginal DHEA, prasterone, which is the brand name Intrarosa, all can help with the GSM and will not have systemic absorption. So many women who are uncomfortable about systemic hormone therapy should not be worried about vaginal hormone therapy. Even breast cancer survivors, the only caveat would be those women who are on aromatase inhibitors need to have that conversation with their oncologist and their prescribing gynecologist or primary care physician. That's the only, and many of them can still be eligible for vaginal hormones too, but that's the only category where you would have to have that conversation. Everybody else, really, any symptoms, and it's not that you take it and then you're done. This is something you will be taking forever. So if that was going to be a question of how long do you need to be on it, forever. You have a starting dose of every day for about 2 weeks, and then about twice a week for the rest of your life.
So someone asked the question that their doctor, healthcare provider, will not prescribe a topical estrogen, whereas we are now hearing pretty uniformly from the doctors and experts we brought on our menopause talks that women with pain or other genital urinary symptoms should definitely take a vaginal estrogen. So two questions there's: why are many people's doctors still resisting it? And what can a patient say or show the doctor to get them to prescribe vaginal estrogen if need be?
Well, and you said topical estrogen, which there are systemic forms of topical. So we're talking about vaginal estrogen.
Yeah.
And so I would say that maybe the doctor is, if it's doctor, uninformed, and I would probably get a second opinion. Or, you can talk about the fact that most medical societies, the American College of OBGYN, the Menopause Society, formerly known as NAMS, would support the use of vaginal estrogens, even in patients who had a history of breast cancer. Again, the caveat being, if you're on an aromatase inhibitor, that may be the time where the clinician says, no, I'm not comfortable with that. But otherwise, there's probably not many reasons why. And get a second opinion. I don't know the particulars of that particular patient, so I can't say for sure, of course. But for most women, you should be on it. And in fact, I was just reading a study about mortality for UTIs and women that go into the hospital with UTIs. And I have to say that we should be thinking about that, because even in the elderly, and by elderly, think about a woman who's in her 80s and 90s, says, well, why should I be on vaginal hormones anymore? Because you need to also protect against frequent UTIs, because that actually can be a leading cause of death for many women who end up in the hospital because of them.
So someone asked a question: if you take vaginal estrogen, do you need to take progesterone with it?
No.
Okay.
You do not. There is no systemic absorption or a little teeny bit of systemic absorption. And clinical guidelines say for the amount of estrogen that you're getting in a vaginal estrogen, you do not need a progestogen.
So we have another.
Wait, can I also say though, and again, I'm not giving medical advice, I'm the psychologist here, but if you are bleeding, and I will tell you that any clinician will say, if you have unexplained bleeding, you should talk to your healthcare professional, right? You should. But back to the original question, do you need a progestogen for vaginal estrogen, local vaginal estrogen? No.
So there is a black box warning on vaginal estrogen. Can you explain to us if given what you're saying, why there's a black box warning, and what is the history behind people's efforts to try to change that?
The FDA has their boxed warnings on things because they're there to provide safety. However, in this case, the reason why vaginal hormone estrogen has that same boxed warning is because they see estrogen as a class, and they lump systemic estrogen with vaginal estrogen. So even though the dosing is hugely different, and there's, again, very little, if any, systemic absorption, they give you the same boxed warning, which, by the way, is the data doesn't even support it tells you risk of breast cancer, risk of stroke, risk of dementia. There are so many things, and we're not going to talk about systemic estrogen today, that the data would suggest that is not those risks anymore, even for systemic estrogen, but certainly not for vaginal estrogen.
We're gonna stay on this topic a little longer, as we knew we would, because there is a question about someone using Intrarosa and feeling irritable from it, and they've done a test twice. So you're basically saying there's minimal absorption into the system. And someone else actually said they tried it and they experienced cramps. So tell us, when someone thinks they're experiencing something else when they're taking vaginal estrogen, what could be going on there?
I wouldn't discount it. First of all, and I didn't get to talk about Intrarosa too much. So I will start with, some women will experience some symptoms that they are just very sensitive to even the minimal amount of absorption that will, particularly initially, if you have thin lining. But I will tell you that the best way to understand the amount of systemic absorption of vaginal estrogen, or in this case, vaginal DHEA, is 1 year's worth of the amount of systemic absorption. The amount of systemic absorption of 1 year's worth of a vaginal estrogen is the equivalent of about 2 birth control pills. Okay, 2 birth control pills. And so think about all the birth control pills many women have been taking over the years. Two pills is a year's worth of the systemic absorption of vaginal estrogen. Now, Intrarosa, which is dihydroepiandrosterone, it's actually a precursor to hormones. It's a steroid that, when it gets into the tissue, it acts like an estrogen and a testosterone, or an androgen. And so and in fact, we did a trial, because I was the principal investigator on this, looking at whether Intrarosa could actually have a feedback loop to the brain to impact desire, because the idea would be, if you can have the change in the urogenital tract and allow for more arousal, that might create a feedback loop to the brain to allow for more desire. It did not show that effect, so it did not get the indication for desire. But there are impacts on having those urogenital tissues changed. So that is what Intrarosa does. I'm not quite sure about the irritability, but if you have side effects and you don't like something, there are so many other options in the vaginal hormone world. You'll probably find something that won't cause you a side effect.
When you mean other options, you mean just other brands or modes of delivery of the estrogen?
Right. If Intrarosa is not a good fit, and that's a 7 days a week, then try a vaginal estrogen. Or you can, talk to your clinician about maybe a spemifene, which is a SERM, a selective estrogen reuptake modulator. So, and that's the oral version. But you can use, for example, Imvexxy has a 4 microgram dose and a 10 microgram dose. So if you feel like a little bit higher dose of estrogen is causing you a side effect, then go to the lower dose.
By the way, we will share a transcript, so all the words that Dr. Kingsberg is saying, we'll make sure you know them. So someone said, you
cut out the though, please.
Yeah, we will. So someone said, you said about different doses. Someone asked, can you break a suppository in half? Is there anything preventing you from doing that?
I cannot give that medical advice. You need to talk to your clinician about whether or not you can, the suppositories are hard to break, they're kind of shaped to be sort of a pellet, and they could get a little messy, but talk to your clinician about if you can break it in half and use half the dose.
So someone asked an important question that their doctor has given them vaginal estrogen, but have said to only put a small amount on their finger in the opening of the vagina. So can you now clarify, there are said some women who may not need a vaginal estrogen or have a vaginal estrogen, but may also need some kind of lubricant during sex or some kind of moisturizer all the time to keep the vagina in health. So I want to understand,
Sure.
rubbing vaginal estrogen, a lubricant, a moisturizer. Tell us what the difference are.
So going to your first part first, which is with the advantage of using a vaginal cream is that you can pinpoint where you're going to place it. And sometimes when you insert, it comes with an applicator, use the applicator, or put the dosing out on your finger and you can insert with your finger if you don't like using the applicator. Many women are like, oh, I can't ever get it really clean. It's this plastic thing and I don't like it. Use your finger. But what's also nice is, particularly if you have symptoms of dryness or pain right at the entrance, and remember that, even the clitoris can feel the effect of that lack of blood flow, then sometimes putting a little on the vestibule, it can be very helpful. So you can sort of pinpoint the dose. Now, that said, that is the vaginal estrogen or vaginal hormone will help with the tissue, right? And that should help with lubrication. And it should help with creating the thick lining of the vagina and the vestibule that it had before. But when we think about treatments, as you pointed out, not everybody will need an estrogen. And remember, there's maybe 20 to 30% of women who will not develop GSM. They still might need a lubricant. And a lubricant is short-term. You use it for sexual activity. It helps with creating, reducing friction and allowing that sort of slippery feeling that your body used to create and may not as much, although, it's a multi-million dollar industry, and millions of premenopausal women who are not postmenopausal, who don't have GSM, still require a lubricant. Lubricants come as water-based or silicone-based. You want to try and get one, and here's a word, osmolality. You got to find the right osmolality. It might say it on, we'll get the numbers later in terms of the right level of osmolality, but there's some lubricants that will pull moisture out and some that will help with moisture. Honestly, try a few. And if it feels like it's more drying, get a different one. Some will be paraben free if you're very sensitive to sort of those fillers, and you can find some of the nicer ones that will allow for just a nice, easy lubricant. Use a lubricant during sexual activity. A moisturizer is just like you would moisturize the rest of your body with, whatever, your Cetaphil lotion. And you would use that a couple of times a week, not during sexual activity, because you would moisturize it just like you moisturize your skin. It will help give back some moisture, but it will not help address the tissue change that the lack of hormones has caused. And that's where the vaginal hormone therapy comes in. That actually will treat the underlying tissue that's been causing the problem. So lubricants during sex, moisturizers to help just keep the skin moist and soothing, and the hormone therapy to actually treat the tissue.
And here's one question about lubricants. You see water lubricants and you see silicone lubricants. What generally do you recommend, a water or a silicone?
Well, it is personal preference. The silicone lubricants will last longer. They tend to be a little bit more slippery, and so you don't have to reapply as frequently. They are very slippery. We always just talk about, don't use them in the shower because you're going to slip and fall. So be very careful about how slippery they are. But you can't use silicone lubricants with all sexual tools or toys. Some that are made of silicone will not be compatible. So you need to just pay attention to what you're using them with, and try a few. And many lubricants will or brands will have a water-based version and a silicone-based version. They're not very expensive. Buy a few, try them out.
So your mentioning of sexual tools leads us to the topic of orgasms. And a number of people have asked. One person said it's very hard to reach an orgasm. And another one said it takes much longer time to do so. You know, members of our audience have said that they can't have one at all. So I want you to first explain why biologically it becomes harder, and what are the options for women?
Sure. Well, nobody explains it better than Dr. Stryker, so I'm sure she's been on before. And if you haven't heard her transcript or read it or seen, I'm sure it's out there. But as we age, the one thing that does change for women, among other things, in terms of our sexual function, while desire may not decline, our ability to reach orgasm does change. The tissue and the nerve fibers does change. And while other forms of stimulation might have worked before, you may now need the vibration, because those nerve endings that respond to vibration are the last to go. Thankfully, they are the last to go, and vibration often will be the mechanism that is the most reliable for reaching orgasm. I still think you need to pay attention to whether you have symptoms of GSM and that you have a lack of genital sensitivity. And some of that may be an arousal issue. And for that, I may have mentioned the last time, we're working on a clinical trial that we're waiting for the results of a clinical trial looking at a topical Viagra, topical sildenafil that may help with women's arousal, because you need enough stimulation and arousal and blood flow to get aroused to then trigger that orgasm. But for many women, they'll say, look, the arousal's there, but I still can't trigger that orgasm. So again, vibration often is the case. Many women relied on vibrators anyway. About 40% of women are reliably orgasmic with using vibration. It is, again, multi-million-dollar industry, and way more than 50% of women in the US own a vibrator. And so many will say, I've always had to rely on a vibration and a vibrator to trigger orgasm. Other women said, I didn't used to, but now I do. And so that needs to be the hardest part about using a vibrator, is if you have a partner, incorporating that with your partner if you didn't used to, so that your partner can understand it is physiologically necessary now. It's not about them not being a great lover or not being stimulating enough. It is physiologic, and how to bring that, which is why you call it a tool, not a toy, into the bedroom with a partner. And if it's self-stimulation, you may need a stronger vibrator than you used to have. Some women will say, oh, I have this bullet. And well, the bullet is, hardly vibrating at all. You need to go find, and there are many websites. My favorite is Good Vibes, goodvibes.com, because it is really for women. It was started by a woman in the 70s who wanted a place for women to go. It was actually before the internet. So where women could go and feel safe and comfortable getting things like lubricants and vibrators. So you need to, again, experiment a little and find the kind that works best for you. Again, something that is going to be more external, probably going to work the best. And can I also put a plug in for, think about what medicines you might be on, because some medications may have an impact on orgasmic attainment. The SSRI, selective serotonin reuptake inhibitors, are a big culprit for that. Some will impact desire, but many will impact the ability to reach orgasm. In fact, we use those SSRIs off-label for men who have premature ejaculation because it does delay orgasm.
Right. I mean, I'm actually on an antidepressant, and for me, I need to take a drug holiday for a day. Do you recommend, is that one strategy you recommend for your patients on antidepressants, or are there other?
If it works for you, that's great. For many women, it's not, the half-life will not be, short enough to allow you that drug holiday before being off the antidepressant has a negative effect. So, some will try For example, bupropion as an antidote. There is no data that it works as an antidote.
That's Wellbutrin, just so people know.
And there will be other, hopefully other treatments coming that might work as an antidote to the sexual side effects, but it really is a cost benefit in terms of how important is the SSRI to your functioning versus how frustrating it is to have that sexual side effect and or talk to your, lots of women don't talk to the person prescribing their SSRI about those sexual side effects. Please do, and maybe they can put you on a different antidepressant that might have a benefit.
So tell us how testosterone fits into the picture. There's a lot of discussion about it. If you could explain its safety and also for which of the four components does it most effectively address? And then in what form is it safe for women to take?
Sure. Well, there are some providers when there is vestibular problems that may use a little compounded estrogen testosterone cream, but that really is for a local effect when estrogen alone, vaginal estrogen isn't quite enough, but that's going to be a separate category. Testosterone for postmenopausal women, there has been a global consensus paper of which I'm an author, and ISWISH, the International Society for Study of Women's Sexual Health, has a clinical practice guideline for the use of testosterone in peri and postmenopausal women because the evidence has shown that it is an effective treatment for hypoactive sexual desire disorder in peri and postmenopausal women. Not necessarily pre, but peri and postmenopausal women. Along with estrogen.
What does that mean, hyposexual?
Loss of sexual desire that causes you personal distress. If you have no desire and you're not bothered by it, then we don't really want to treat it. But if you are distressed by it, hypo means less than. So loss of sexual desire, and that it sort of occurred as you were aging. Along with the loss of estrogen, your ovaries are producing 50% of your testosterone, and we women have testosterone. And as our ovaries are aging, we're losing testosterone. So our peak level of testosterone in our ovaries, or as we experience it, 50% in our ovaries, 50% in the adrenal glands, is in our mid-20s. And then it's sort of a gradual downhill from there. But by the time we're in our 50s, our testosterone is half of what it was in our 20s. And so many women will experience a change in their desire because testosterone really is important for desire in males and females. And so many women will experience that change and will feel that their desire has gone down. And so we know that giving back testosterone to the level that it brings you back to your premenopausal levels, about the level you had in your 30s, has been an effective treatment for loss of sexual desire in some women. Okay, we know that it's efficacious. The long-term safety, we have some long-term safety data. There is not one approved testosterone option for women anywhere in the world except for in Australia. They do have one approved medication in Australia. Every place else, it is what we call off-label use, that your clinician has to prescribe it as an off-label and talk to you about using something that doesn't have an approved indication. But we know that about 20% of all prescriptions in the US written for testosterone are written for women, postmenopausal women with low sexual desire. That's what it shows its efficacy for. So we often will use the FDA-approved male version because we want an FDA-approved dose medication. And it comes, for example, as a tube. 1 day's use of the tube, one tube would be 1 day's dose for a male, and we would have women use about 1/10 of that dose. Okay, so you and your clinician can figure out how to dose that out, but it's about 1/10 to give you back to your premenopausal level. That is the goal. Okay, and so we do know that it has been used safely in women for decades, assuming we bring them back to their premenopausal level.
So on the issue of testosterone, and orgasm and pain, in the chat, we posted a link to our website, Let's Talk Menopause, where we now have the recordings for our sessions at our Menoposium, our live symposium in March. Of course, Dr. Kingsberg was there on 2 of our panels, and one of the panels is devoted completely to urinary and sexual issues during and after menopause. So we strongly encourage everybody to go if you have other questions and listen to that. And also there are a few questions here about, there's some questions that are more general about systemic estrogen. And we actually, our first panel during our Menoposium was largely devoted to that question. So we definitely encourage you to go.
And there's no better speaker than you had, Robin, and you had Mary Jane Mencken. She's the
right. So that is fascinating. Just so you know, there's a debate there on the safety of pellets.
Well, that was going to be a thank you for reading my mind. I just wanted to say, please, we do not support the use of pellets. That will bring you to a super physiologic level that, what many women think of a little is good, a lot is better. It is not. That brings you to a much more, dangerous level, and pellets you can't take it out, and it brings you to a super physiologic level. So we do not support the use of an oral, an injectable, or a pellet testosterone option.
So just one other thing, because we know how extremely difficult it is to find doctors and even gynecologists who have the knowledge that we need to be treated effectively, which is one of the reasons we've started Let's Talk Menopause. On our website under Find a Provider, you can go in and put your zip code and find a practitioner. So Dr. Kingsberg, though, you actually now are available to be a provider for people across many states. Can you explain that briefly?
Well, I have to say that psychology as a profession managed to work out what's called PsyPact, which allows you to apply for and get telehealth reciprocal privileges in any other state, that if your state has it, then it provides reciprocity in other states that have it approved. And it actually has to go through the state legislature. It has to pass the House and the Senate. So Ohio has passed it, and so I applied and now have my PsyPact license that allows me to practice reciprocally telehealth in about 30 plus states at this point. And I think it will continue to grow, but there are about 30 states that have passed that. And so any state that you are in that is in the PsyPact state, and you can Google it, it'll tell you, allows somebody like me who is a clinical psychologist to see you in those states.
We just want to say thank you so much, Dr. Kingsberg. We can't promise that this will be your last menopause talk with us, but we really appreciate your continuing willingness to come and advise us all. We are excited that our next menopause talk is on treating depression and anxiety during midlife and the menopause transition. Dr. Suarez has done amazing studies showing what treatments work, don't work, and during what phase, whether it's perimenopause, menopausal, or long-term, also based on your psychiatric history, which is why we wanted that level of expertise. So please join us for that. We want to thank you again. We are going to release the survey now. If you don't have time to do it, it's 3 short questions. Then we will send you a link. And thank you so much for participating.